Lesson 2, Physiology of Life and Death. All of our body systems are interrelated and interdependent upon each other. Oxygen is provided through the lungs. Glucose is provided into the Krebs cycle to provide energy with the oxygen. That must be delivered to the cells. Hormones must be delivered. Waste products must be removed through the kidneys and liver. Everything depends on each other to function properly. Every cell and organ works together to sustain this energy production and to maintain the vital metabolic processes that keep life going. Energy is required to power all body functions, and it sustains the cellular and organ function. Without it, these organs will die. Cells make energy from oxygen and glucose, and it is stored in the form of adenosine triphosphate or ATP molecules. Without energy, the cellular functions will cease. The goal is to make sure that the patient's body maintains energy production. The airway must be patent. In other words, it must be clear from obstructions. It must be clear from anything that will keep oxygen and air from getting into the patient's lungs. This may include things such as broken teeth, swelling, etc. We must have adequate breathing. Adequate ventilation must provide oxygen, which must get to the alveoli. It must cross the alveolar capillary wall and enter into the circulation. At the same time, carbon dioxide must be removed from the circulation as well through the lungs. Circulation will help distribute that oxygen via red blood cells. So we must have adequate red blood cells. And these red blood cells also must have adequate hemoglobin on them. And there must not be anything to interfere with the absorption of oxygen into the hemoglobin, such as carbon monoxide, etc. The red blood cells must move adequately through the circulatory system to transport the oxygen to the cells throughout the body. So the airway must be open and patient. When we say that there must be normal air movement, turbulent airflow through obstructions, through swelling, through anything that would keep the air from moving in a nice fashion into the lungs will decrease the amount of oxygen that gets to the lungs and increase the patient's work of breathing. Air will come in through negative intrathoracic pressure. As we take a breath, our diaphragm contracts, the chest wall expands. This creates a negative pressure in the lungs that will draw air in. Without that negative pressure, the patient cannot adequately ventilate. To exhale, the patient would provide his own positive pressure from the inside. The diaphragm will relax, contracting upwards. The chest wall will fall inwards, contracting or pushing onto the lungs, and this will help provide that positive pressure to force the air out of the alveoli and out of the lungs. Without that positive pressure, the patient may not be able to exhale appropriately. Patients who have obstructed breathing, such as asthma, such as swelling from burns and things of that nature, may not be able to get adequate air in or provide enough positive pressure to push the air out, or it may be delayed in leaving the lungs. When breathing, adequate ventilation will get the air into the lungs, the oxygen will come in, and there must be enough negative pressure that the air actually reaches all the way in and through to the alveoli. Shallow, gasping respiration may not have enough negative pressure to draw the air in far enough and would not provide enough oxygen for the patient. When the air does reach the alveoli, oxygen will cross the alveolar capillary membrane and go into the circulatory system, and at that time carbon dioxide would leave the circulatory system and come out into the lungs to be exhaled. As the oxygen enters into the circulatory system, it attaches to the hemoglobin on the red blood cells to be carried and transported throughout the body. Carbon dioxide, which is a byproduct of metabolism, is an acid that is released through exhalation. As it crosses the alveolar capillary membrane, at this time, oxygen is moving in. So the two must have the appropriate pressures in order to move in the directions that they need to. If there is too much pressure in the alveoli, the CO2 may not be able to leave. It is removed during exhalation, so again, it is important that the airway be clear and the patient be able to adequately exhale to get rid of that carbon dioxide. If it is not removed, it may stay in the alveoli or stay in the capillaries, and the patient will not be properly oxygenated. In the circulatory system, we rely on a couple of different things to make it work effectively. We must have a heart that is able to pump appropriately. We must have intact blood vessels, and we must have enough red blood cells to carry this oxygen throughout the body. If any one of these things does not work appropriately, we may not be able to transport that oxygen to the patient. Oxygen will be transported throughout the body, and when it reaches the capillaries, will be released into the cells to be used to make energy. At this time, when the oxygen is moving in, carbon dioxide, primarily in the form of hydrogen ions, will be released into the bloodstream where it will bind with bicarbonate to form carbonic acid. This will break down into carbon dioxide, which will then be transported through the venous system to return to the lungs to be exhaled. Aerobic metabolism is the method by which our body makes energy. It is very efficient and produces a lot of energy with only a little bit of waste. Some of you may know this as the glycolysis cycle, also called the Krebs cycle. And the two main components are oxygen and glucose. The waste products, like I just said, are carbon dioxide and water from the breakdown of carbonic acid. Aerobic metabolism is dependent upon an adequate and continuous supply of oxygen. Any interruption in that oxygen supply may result in periods of hypoxia, which may result in the cells having to rely on anaerobic metabolism, which we will discuss next. A patent airway provides a clear path for air to enter into the lungs. The lungs must be functioning properly, and we've said a functioning heart must be there to pump that blood containing the oxygen throughout the body. The intact vascular system, we don't want to lose the blood. The blood carries the oxygen, which is why it is so important that we stop hemorrhage. We also must have a good, adequate supply of red blood cells to carry and transport the oxygen. Some patients may be at risk for having a problem with this, such as elderly patients, anemic patients, etc. It is very important that the oxygen not only be delivered, but that the waste product be taken away by the red blood cells and be eliminated through the kidneys, carbon dioxide through the lungs, etc. So here's our picture of aerobic metabolism showing the different components that are required. All three of these components, the airway, the lungs, the circulation and perfusion, all of these must be functioning properly in order for aerobic metabolism to work and to produce the ATP or energy required to fuel the body. If one of these things, take away the airway, take away the lungs, take away the perfusion, even if the other two are good, one of those things goes away, all three will eventually fail. If there is no airway, then oxygen doesn't get through the lungs, and no matter how good the circulation is, there will be no oxygen circulating to the cells. Take away adequate circulation, and great breathing will get you oxygen that isn't going to go anywhere. All three of these must be working properly for the aerobic metabolism or Krebs cycle to work like it should. If there's a fault or injury that affects any one of those three things, airway, breathing, or circulation, then anaerobic metabolism will start. Anaerobic metabolism is a process that functions when we do not have oxygen delivered to the cells to help function in the Krebs cycle. The problem with anaerobic metabolism is that it uses glucose to create energy, but without oxygen, we burn the glucose and we get a small amount of energy, but we get a big increase in waste product. When compared to aerobic metabolism, which produces a lot of energy with a little bit of waste, anaerobic metabolism is the exact opposite. A lot of waste with a little bit of energy. If you think about this over a period of time, 10 minutes, 20 minutes, 30 minutes, the waste will far exceed the energy. And if the body is not able to get rid of that waste, will become acidotic, and that is a poor environment for the body to function in. So we have an obstructed airway that creates hypoxia, not enough oxygen getting in. Or maybe we have a lung issue such as a pneumo, tension pneumo, flail chest, pulmonary contusion, something that prevents air from getting in through the alveoli and into the bloodstream. Or poor circulation due to hypoperfusion, blood loss, poor cardiac function from a tension pneumo or tamponade. These may all impair the delivery of oxygen, and the cells without oxygen will turn to anaerobic metabolism, and energy production will drop, and waste product will be created at a much larger and faster way. This will lead eventually to shock. Without adequate energy production and delivery of those energies to the cells, the body will go into shock. Changing from aerobic to anaerobic metabolism is a twofold problem, a decrease in energy with more waste. Although this will help for a very brief period of time, eventually the body will not be able to meet its metabolic demands, energy production will decrease, and the cells will begin to die. Hypoperfusion could be cellular hypoxia, not enough oxygen reaching those cells, decreased ATP or energy production, and cell dysfunction because of lactic acid buildup. Low pH. Remember, as pH goes down in number, the acidity is increasing. An acidic environment with lactic acid, with no energy and no oxygen is not good for our cells. Cell dysfunction includes autodigestion of the cells, where the cells will actually start to die and the organs will start to die. Sodium will enter into the cells or increase in the cells and also pull in water. This could lead to edema. This could lead to cellular death because the cells will actually explode due to too much fluid inside. In the brain, this could lead to cellular edema. And this could be a problem if we're giving the patient large amounts of fluid. We may actually worsen this problem or contribute to it. If the oxygen does not reach the red blood cells in the capillaries, this problem will also continue through hypoxia of those cells and those organs. Loss of blood volume will just further expound on this and cause a further decrease in oxygenation. Inadequate ATP production because of poor oxygenation will lead to the cells not getting enough oxygen. As the cells do not function properly, metabolism creates heat, and heat is what gives us our normal body temperature. So if the cells are not producing properly or not metabolizing effectively like they should, they will not produce heat, and this will lead to hypothermia. Hypothermia, acidosis, these are all things that are bad for our patient. As acidosis sets in and metabolism decreases, body temperature decreases, the body will try to correct temperature through shivering. So now what little ATP we are producing is going to be used to supply the muscles to shiver to raise body temperature so we can get to a normal temperature and function. However, the shivering produces more lactic acid, the anaerobic metabolism produces more lactic acid, and eventually this will interfere with those muscles being able to function at all. Coagulopathies will occur as well. As the body temperature drops, clotting becomes impaired, and any bleeding that is going on may go unchecked now because we will not have the ability to clot properly. Hypothermia, acidosis, and coagulopathy, these are all called the trauma triad or triangle of death. Any of these things will lead to the other, which will eventually lead to energy loss, which will eventually lead to the death of your patient. It is so important that we prevent all of these things. Trauma patients need to be oxygenated so acidosis doesn't occur. We need to keep them warm. We need to make sure that bleeding is controlled. These three things, the trauma triad of death, are going to cause your patient to die. And it is your job to, as early as possible, prevent these things. This is why trauma bays at the trauma centers are kept warm now. This is why all trauma patients receive high flow oxygen. This is why stopping bleeding is so important, and why research and scientists are looking at ways of giving us in the field methods to control bleeding. These three things must be stopped, prevented, or reversed, or your patient will die. So anaerobic metabolism, we said, will lead to a decreased energy production. Decreased energy in the cells leads to cellular death. If the cells do not have energy to stay alive, eventually they will die. When enough cells die, the organs die. And when organs such as the liver, the kidneys, the brain, when they die, your patient is going to die as well. So the different types of shock. We have hypovolemic shock, which could come from dehydration or hemorrhage. Distributive shock, neurogenic, and also septic, anaphylactic, or psychogenic, fainting. Cardiogenic could be from pump failure, and that could be intrinsic from something in the heart, or extrinsic where something is actually interfering with the heart. In shocks from trauma, hemorrhage is the #1 cause of death and the #1 hypovolemic issue. There could be some dehydration in patients with burns from plasma movement, but hemorrhage is the #1 cause of death from shock related to hypovolemia. Distributive shock in trauma patients most often comes in the form of neurogenic shock, which is from a spinal cord injury. Septic and anaphylactic generally tend to be more of a medical cause. And in cardiogenic shock, it's the extrinsic factors that cause pump failures, most commonly things such as cardiac tamponade or tension pneumothorax. Hemorrhagic shock, like we said, the number one cause is of death. Internal or external blood loss. There is no excuse for external blood loss to occur. One of the things that we need to do in that primary survey as part of the C is circulation, is stop any external blood loss. Every drop of blood matters. Every drop counts. Let's stop that blood loss as quickly as possible. Internal is going to be found when we do our assessments and our reassessments, and we watch for those places where that may occur, such as the abdomen, pelvis, etc. There are your different classes of shock, class 1, 2, 3, and 4, and you can read through those numbers and see what you're looking for. Neurogenic shock is usually associated with spinal cord injury. When this happens, there is a loss of sympathetic stimulation to the spinal cord going out to the target receptors. Sympathetic stimulation is what keeps your blood vessels in a slightly constricted state. When those vessels do not have that sympathetic stimulation, the only thing they can do is dilate. This results in massive systemic vasodilation. This results in a larger container. You may still have the same amount of blood or fluid, but it's in a much larger space. This results in a shock state. You will be hypoperfused because you do not have enough volume to fill the container. In cardiogenic shock, this occurs generally from the extrinsic factors when the heart is compressed or interfered with its pumping ability. The heart needs to be able to fill so it can expand, so it can contract and eject the blood. If the ventricles cannot fill fully, then what will happen is less blood in means less blood out. We may be able to compensate a little bit with heart rate increases and trying to contract harder, but those factors are temporary and will not be able to overcome the decrease in output. The big two causes that we see most often from trauma are pericardial tamponade and tension pneumothorax. So shock, it is progressive. It will start and continue, and different compensatory mechanisms will kick in to try to prevent this or delay it from progressing, but its progression is inevitable. There could be hemodynamic changes such as blood pressure, heart rate. You might see cellular changes such as an increase in acidosis. Now, we as pre-hospital providers would not be able to test for this unless you're doing lactic acid testing, and there's some controversy as to whether that's effective or not in trauma patients, but it is one way that we could look to see if there is any metabolic changes. And microvascular changes we would not be able to see, but those microvascular changes may lead to organ death. Those compensatory mechanisms are short-term. They're only designed to work right then to help us out, but eventually they will fail if you do not take the proper steps to intervene to alleviate those compensatory mechanisms from being used. The heart must pump effectively. We said earlier it must fill in order to expand, to contract properly, and that is called Starling's law. Blood must return. The preload coming back into the heart through the vena cava must be significant enough to fill, and when it's pumped over to the left side to be pumped out, if there's not enough blood or pressure or volume, then the heart will not fill enough, and then its output will be decreased. The output is the stroke volume, and this is the amount of blood that's ejected each time the heart beats. You need an adequate return in. With that decreased preload, you won't have enough, and the body will have to compensate to make up for the lost volume. The cardiac output is the stroke volume times the heart rate. And this is very important. This formula right here is our formula of life. The cardiac output depends on the volume, and if the volume decreases, the heart rate will increase to compensate for it. That compensation, though, is short term. The heart can only pump so hard, so long, before it will become ineffective. And at that point, when heart rate decreases because it can't keep up anymore because of not enough oxygen or not enough energy, when that decreases, The volume is already decreased. That will lead to a decrease in cardiac output. And why that's so important is because cardiac output has a direct result on your blood pressure. You can see the formula on the bottom. The blood pressure is dependent on the cardiac output times your systemic vascular resistance. You need an adequate pressure to move the blood through the system. If the pressure decreases, then the volume of blood may be the same. But if it doesn't have enough pressure, it may not make it through the pipes or through the system, reaching those target organs. One of the first places that it starts to be noticed is in the distal perfusion of the hands and feet. But it will eventually make it to the core, and when it makes it to the core, if the pressure is not adequate, organs will start to fail. As that cardiac output starts to drop, we will vasoconstrict, and we will constrict and constrict and constrict as much as we have to try to keep the core pressure up. But eventually, that's going to fail as well. So the formula on the bottom shows you that blood pressure equals cardiac output times systemic vascular resistance. So we really have two things that need to happen. We need to have an adequate stroke volume or heart rate to compensate, and we need to have an adequate vasoconstriction in order to provide that. So if we take the hypovolemic patient, you can see that they're going to have poor stroke volume. If we take the neurogenic shock patient, you can see that they're going to have poor systemic vascular resistance. All of these things will eventually lead to poor blood pressure and poor perfusion. If we had a cardiac patient who had tamponade or tension pneumothorax, the inability to pump effectively would lead to poor cardiac output as well. So all of these things are eventually going to lead to shock. The vasoconstriction, as it becomes more and more constricting in those capillaries, is going to start to cause changes to the tissue that it is supplying oxygen to. We have what's called a precapillary and a postcapillary sphincter. These are little control valves in front and at the end of each capillary. Those will start to constrict early, which will result in less blood getting to those capillaries. Remember, it's at those capillaries that oxygen is delivered to the tissues, not in the vessels, not in the arteries, not in the aorta. It is delivered at the capillaries. So if we constrict before and after, we're not only going to have not enough blood getting into the capillaries, but then we won't have what's getting in, it will have a hard time getting out to return back to the body. Without oxygen, the cells that are normally supplied through these capillaries will have to turn to anaerobic metabolism, and we've already discussed the problems with that: decreased energy, increased acid production. As the acidosis increases, which we know it will because of the anaerobic metabolism, the precapillary sphincter coming in will open. This will allow blood to come in, but the postcapillary sphincter on the end will still be constricted or closed, which will not allow the blood to leave. So now we have blood coming in but staying there. It won't move, it won't go anywhere, and this will cause a stagnation of the blood in the capillary. And we know what happens when blood becomes stagnant. It's going to start to coagulate. Eventually, the postcapillary sphincter will relax, so now the blood will flow through this area. The problem is it's going to flow through an area where there's a lot of acidosis, and we know that there may be some clots, microemboli, because the blood has been stagnant. So now you have blood with clots, blood with acid coming back through these vessels to return to the heart. In some organs, those microemboli may continue to block or clog up those vessels, causing infarction or death of more cells further down the line. So when we look at the different types of shocks, the three main ones, hypovolemic, neurogenic, and cardiogenic, we can see some differences that we might want to pay attention to. The hypovolemic patient tends to have that cool, clammy, pale skin, whereas a neurogenic patient may have warm, dry, and even pink or flushed skin. The cardiogenic patient would be cool, clammy, and pale and cyanotic, resembling the hypovolemic patient, so we would have to be able to look further to find out what their problem is. The blood pressure in all three of these patients will drop. In the hypovolemic patient, as blood pressure drops, they become altered. In the cardiogenic patient, again, as cardiac output decreases, they become altered. But in the neurogenic shock patient, usually the shock is below where the cord injury occurs. So the patient may have inadequate or even hypertensive blood pressure above that. That may result in a patient who is awake, alert, and oriented, as opposed to the altered or decreasing level of consciousness we see in the other two shocks. The capillary refill time will be slowed in the cardiogenic and hypovolemic patient, but in the neurogenic patient, they may have a normal capillary refill time, especially in the upper extremities. So some minor differences, but things that make you go, why is this different than what I'm expecting to find? And it may be because they have a different type of injury than what you're expecting. Shock, if it is not recognized and promptly corrected, will eventually lead to organ dysfunction. The dysfunction of this organ will have a cascading effect on the rest of the body, and the inability of the organ to function properly may also lead to further deterioration of that organ and eventually to the death of that organ, which may eventually or will probably eventually lead to the death of the patient. Some of the organs are very oxygen sensitive, such as the brain. Some are more pressure sensitive or blood pressure sensitive, such as the kidneys. But eventually, patients will die. Organ systems fail, mortality rate, you can see there approaches 100%, and at that point may be too late even to save your patient. So like we said, brain, heart, lungs, very sensitive to pressure and oxygen. The blood pressure issue with the kidneys, liver, etc., GI tract, and muscle, bone, skin, they have the ability to bounce back a lot more effectively with longer times of not enough perfusion. But that brain, heart, lungs, and the kidneys, those are the ones that we absolutely must make sure that they're getting enough oxygen and getting enough pressure. Renal failure, you can see there if oxygen delivery is impaired for more than 45 to 60 minutes, which seems like a long time when doing a lecture, but in real time, if you factor in that the injury occurred, it may be 5 or 10 minutes until someone notices, or maybe they call right away, but delivery time to get to the patient, package the patient, transport the patient, get them to the hospital, get that recognized, get them to surgery, that golden hour can be eaten up pretty quickly. Without good kidney function, decreased renal output, you're not reducing or clearing your toxins that the kidneys are designed to get rid of. Those will build up in the body, electrolyte imbalances, etc., and this will cause further issues with other organs or even death. ARDS, or acute respiratory distress syndrome, is a condition that results from damage to the alveolar cells. This can happen from hyperresuscitation, this can happen from chemical issues, burns issues, things like that, where the lungs get damaged. But what generally happens is there's a leakage of fluid into the interstitial spaces and the alveoli. The problem this creates is fluid in those spaces makes it more difficult for oxygen to go across the cells. Hematologic failure, the impaired clotting cascade, which we said can happen from hypothermia, can also happen if there's a lot of microclots using up your clotting factors. Right? Dilution of those clotting factors from excessive fluid administration, which is something that we tend to want to give patients, is lots of fluid. That can exacerbate it as well, which is why the tendency or trend now is to use less fluid as a resuscitative measure. Hepatic failure, failure of the liver, again from prolonged shock. An infection that may arise because of breaks in the skin, we're more prone to infection. A decrease in the function of the immune system due to ischemia and loss of energy. These may all put the patient at risk for infection, especially elderly patients. In summary, interruption of oxygen will eventually lead to anaerobic metabolism and should not be allowed to happen. You must do everything you can to make sure that your patient is properly oxygenated. That is step number one. Anaerobic metabolism is inefficient. It does not work well. It is very short term and will just exacerbate or accelerate patient death. At this time, please review and do the questions for this section. Thank you.